David asked me to talk about ablative technologies. I'm going to talk about this going forward. These are my disclosures. They're really irrelevant to the talk that I'm going to give today. So let's talk about what focal therapy is. And really, it's treating significant cancers in a way that preserves prostate tissue. We want to get cancer control with preservation of really function. And this has been used in other specialties, in breast cancer with lumpectomy, with kidney cancer with partial nephrectomy, bladder cancer with transurethral resections of these tumors, thyroid cancer, lung cancer, but it's not really widely used in prostate cancer. And really, I think this slide kind of illustrates the point I'm trying to drive, that whenever you do focal therapy, and what we're doing is trying to minimize toxicities with partial nephrectomies. Really, I think of the years when I would see a 2-centimeter renal tumor, 10, 20 years ago, before the work that was done at the Cleveland Clinic. We would take these kidneys out, and do the total nephrectomies, and now partial nephrectomy really is such the standard of care. In prostate cancer, really the issues are potency, urinary function, and rectal toxicity. So here are the different delivery systems that can exist for focal therapy. They're temperature-based, heat with HIFU and laser ablation, with cold, with cryotherapy. And then we have sort of a smidgen of others with radiotherapy, radiofrequency ablation, electroporation, and even partial prostatectomy can be considered sort of focal therapy as we go forward. This is an article that appeared in European Urology, kind of really understanding and showing some cartoons of what either whole gland or focal ablative therapy is with HIFU, and you can see the list on the right, going all the way down to radiofrequency and brachytherapy, and we'll talk about these in just a second. So really, the bottom line is cancer control versus preservation of function. And I think yesterday we heard a little bit about shared decision making. And there are advantages to focal therapy with less incontinence, the ability to get erections, whether it's an outpatient procedure and what that postoperative period looks like, versus the disadvantages. 1 in 4 focal therapy patients will have a second focal therapy within 5 years. 1 in 15 will have a radical treatment within 5 years. And the patients have to be motivated. They have to be committed to monitoring with PSA and with MRI and biopsy. And I can tell you that as a prostatectomist and doing many of these patients that have had focal therapy that have failed, the radical prostatectomy, the robotic prostatectomy can be a little more challenging as we move forward. But really, I think when we look at the patients, we're looking at clinically significant prostate cancer. We're not looking at patients that have low volume 3+3. We're really looking at patients up to 4+3, unless there's some other particular indication. You must have an MRI, a good quality MRI, and there are some anatomical favorability. The proximity to the apex has to be assessed carefully. Patients that have lesions at the base can be difficult, and the MRI lesions that are visible are much more favorable going forward. So there are a couple of assumptions that we must take into consideration. Unilateral cancers can be identified. Focal therapy can be instituted safely and effectively. It improves quality of life. It does have acceptable oncological outcomes. And then treatment failures can be identified, retreated, or treated by radical therapy successfully. So those are the assumptions. This is a paper from Scott Egner looking at unilateral prostate cancers is a common. In the United States, 2 to 3 separate cancer foci per patient have been noticed. Pathologically, that translates into about 17 to 38%, 28% for low-risk groups, and targeting the index lesion may be sufficient, with only 3% of index tumors contain Gleason grade lower than the overall Gleason score. So there is some planning that goes into this technology. Where the lesions are is important, whether it's anterior, that's where these needle-based therapies are going to be with cryotherapy, electroporation, and even HIFU in some cases. The posterior lesions, HIFU really is a nice treatment for these types of lesions going forward. The Society of Focal Therapy got together and formed a consensus to look at, patient selection and endpoint criteria. This was done in 2014, much from the work when I was at Duke with Tom Palasic, looking at the types of patients that should be done. And it's acceptable. One of the recommendations that came out of this consensus is it's acceptable not to treat Gleason 6 lesions that have a core length less than 5 millimeters. And again, the endpoint, how do we follow these patients with MRIs and biopsies, and what's considered a treatment failure? Cancer of a higher grade, persistent cancer, the need for focal therapy. And again, this consensus conference essentially made recommendations on how we should follow these patients across the board. So in God we trust, but all others we bring the data. So we're going to go through some of the data for some of this. With high-intensity focused ultrasound, all of us know about this. It's a relatively minimally invasive outpatient procedure. It's a targeted procedure. There's low risk of incontinence and erectile dysfunction. There are disadvantages. It may not be appropriate for large prostates or anterior tumors, and it's not recommended for patients that have calcifications in the prostate. Who's the ideal candidate? Well, Gleason 3+4 on biopsy, a lesion that you can see on MRI. The ideal lesions are going to be peripheral, posterior or anterior if it's a small gland, unilateral and away from the apex. You have to have a motivated patient, and they have to be willing to undergo monitoring. And I think that's a real important point. If they're not willing to do that, they may not be a good candidate for focal therapy. So here's a lesion. I think this is a good candidate. You can see this lesion here very nicely on MRI. And the bottom line is the workflow is the probe's inserted into the rectum. You get a reconstruction of the prostate gland. And then essentially, in some ways, this is a robotic procedure, if you will, if you want to consider it that way. And the HIFU targets the cancer cells, causing this brief rise in temperature. Larry Klotz probably has the nicest article on this. It's a really comprehensive article looking at oncological outcomes. You can see the number of patients here ranges from 35 or 8 patients here is a very small series, to over 1,000 patients. But I think the bottom line is I'd like you to just concentrate on in-field recurrences, out-of-field recurrences, and to me, freedom from radical treatment is really the ultimate benchmark, if you will. And you can see these numbers range from upwards of 97% to about 70% across the board. One study here has about a 46% outcome, freedom from radical treatment. Here, if you start looking at complication rates, again, this is this series, but essentially very few complications across the board. A couple of fistulas, those are significant complications in my mind. Retention, hematuria, relatively minor complications, if you will, across the board. This is one of the series looking at almost 600 men, and I just want to show this is the type of data that's published and looking at the composite outcomes. Failure-free survival, avoidance from systemic or significant therapy. Here you can see is the freedom failure-free survival, 88% at 5 years in these patients. Failure is defined as radical treatment, systemic treatment, METs, or death in individuals. PSA, not the best marker, but we do use it as a marker to try to identify patients with treatment failure. You can see the ones that have higher PSAs have a higher treatment failure rate. Failure by Gleason grade, again, very similar. Higher Gleason scores have higher failure rates. It makes very common sense. But there is a little bit of a learning curve, I think. And, patient selection and operator experience clearly make a difference across the board. How should we follow these? This paper made a recommendation of an MRI at a week, PSA at different intervals, and then MRI subsequently in following these patients across the board. Cryoablation, I think all of us know about this. This has been around for quite some time. The workflow is essentially a probe is put in. The probes are then freeze and create this prostate tissue freeze, if you will. And the bottom line is when you look at the data, you can see this is 11 series, almost 2,000 patients. You can see significant cancers in 5.4% and insignificant cancers. Secondary local treatment is about 7%. Toxicity is relatively low across the board. Here again, another series, very similar type data, but when you look at this, incontinence, urinary function, very, very low across the board. I don't want to say a whole lot about stereotactic radiation. I'm not a radiation oncologist, but essentially here's a relatively series that I could find of 2,000 patients, relatively low toxicities, biochemical recurrence rates 4.5% for low-risk disease, 8.6% and 14% for intermediate and unfavorable disease across the board. Finally, focal laser therapy, not a lot in the literature. It is minimally invasive, it's targeted, and the bottom line is essentially a laser probe is put into the prostate tissue to essentially heat the tissue and kill the cancer. The bottom line, not much data in the literature, but you can see, it does seem to preserve erection and incontinence numbers across the board. 17% had some additional therapy at 1 year. I want to just say one word about innovative technology, and this is the innovator's dilemma. If you don't read a book, this is a great book to read. It really says, what the author tries to say, Christensen tries to say is, innovative, disruptive innovation creates new markets. Initially, this doesn't threaten the market. It's not profitable, inferior performance, but with time, improvements seem to allow this disruptive innovation to overtake existing markets and creates new wants. And I think that's what we're looking at with focal therapy. When I think of focal therapy, this potentially is a disruptive innovation going forward across the board. This just lists all the trials going forward, looking at focal therapy, and then the bottom line is the take-home message is focal therapy seems to be appropriate for MRI visible intermediate lesions. You need to assess with MRI and targeted biopsies, and it's a patient-focused approach. Careful discussion of the advantages and disadvantages, and you have to have motivated patients. Thank you very much.